name's Bridie Lynn. I am from Wanganui. My student ID number is 242573031, and today I will be filming my EJV OSCE. So a few things you need to think about when performing an EJV OSCE, or EJV in general, are some of the complications that we can have when we perform them. So things like plastic emboli from sticking the cannula in. The way we can mitigate that is by tractioning when we perform the task. We can cause pneumothorax. We can mitigate that by cannulating at the top half of the EJV. And another issue we can have is failure to cannulate the EJV, which will cause tissuing, hematoma and pain to the patient. So ways we can mitigate that is by practicing as much as possible. So first thing we need to do is don our PPE. If I was in a truck, I would also have glasses. So while I'm doing my PPE, I can show you that I have my gear all set up. So I have my 3ml syringe with 3 mils of saline in it attached to my 14 gauge cannula. I have my lure plug ready to go. I have my fuzzy flush ready to go. I have my Tecoderm ready to go, alcohol swab and gauze, as well as the sharps container ready to go. So first thing we need to do is to gain consent. We can gain consent by asking our patient, hey, I haven't been able to get an IV into anything peripherally, but I really need to give you some fluids and some pain relief. Is it alright if I stick a needle in your neck, but all that will be left in there is a piece of plastic? My patient will say yes, that's fine. If the patient is unconscious, then we can use applied consent. So when performing an EJV, we need to think about positioning. So I want to put my patient's head on a 45-degree angle, like this. Other ways that we can get the distension of the EJV is to ask them to raise their legs, to get them to bear down, or to push on their liver, which puts pressure on the hepatic vein, which helps to pop the artery up. So first thing we want to do is clean the area. So what we'll do is start in small circles and work our way out bigger and bigger, so that area is nice and clean, like that, and put that in the rich bin. Next thing we're going to do is put pressure on the vein so that we can see it pop up. And we're going to grab our cannula, putting tamponade in the vein here. We're going to pop it out and say sharps out. I'm going to warn the patient that there is going to be a sharp poke, and then I'm going to insert the cannula at a 15-degree angle. And then I'm going to pull back, and I've got flashback. So then I'm going to put it in another 3 millimeters, and then I'm going to advance the cannula like that. Still tamponading the vein. I'm going to say sharps out, straight into the sharps container. I'm going to attach my lure plug. Then I'm going to secure the lure plug. I'm going to grab my fuzzy flush, attach it to the lure plug, again pull back. I can see that I am still in the vein, and then I'm going to push 5 mils in. While I'm doing that, I can also see that the cannula is in the vein, it hasn't popped out. I'm going to fasten it now. There's no tissuing, there's no bruising, there's no anything of concern. So I'm going to fasten that with a Tecoderm, like so. I'm going to fasten it again with an extra piece of tape, just over the top there. I also have this piece on the top here where I can write the gauge, the date, so that when we get to hospital they know, and put that on there as well. So make sure there's no infiltration, there's no tissuing. I'm also going to ask my patient if they could please stay in this position so that it doesn't pop out. So it's in, there's no problem with it. I'll document on the EPRF that it's in the external jugular vein. It is a 14 gauge needle. It took me one go, and I will also make sure that I attach some running fluids to it as well. Thank you.